Great. Thank you so much for the warm introduction. And it's a true honor to be with you all here today to present on cardiovascular risk for women, data from the randomized trial to prevent vascular events in HIV, which is also known as the Reprieve trial. The following disclosures here are from myself and also for the Reprieve trial. And in terms of the scope of this presentation, it's important to note that this presentation explores the influence of sex assigned at birth on atherosclerotic cardiovascular disease risk and mechanisms among people with HIV. The terms female and women are used in reference to sex assigned at birth. Efforts to better understand the influence of gender identification and gender-affirming therapies on ASCVD risks and mechanisms among people living with HIV are also important, but will not be covered today. I will also share, if you are interested in this topic, there is a fascinating and excellent paper that were published by Reprieve colleagues looking at characteristics of Reprieve trial participants identifying across the transgender spectrum. And this is available for free via open access at JID, which is the Journal of Infectious Disease, and also on our Reprieve website at reprievetrial.org. So in the next 20 minutes, I will present a brief background on the rationale for the Reprieve trial, including clinical definitions and pathophysiology. Next, I will present the objectives of the Reprieve trial and also the women's sub-study. And this will be followed by a summary of pertinent study findings and sex-specific findings, then implications, resources, and future directions. Globally, people with HIV continue to experience increased rates of non-communicable diseases as they age, and specifically cardiovascular disease. As you will learn in the presentation that will follow mine today, the pathophysiology or source of cardiovascular disease at large in people with HIV is multifactorial and strongly influenced by traditional risk factors shown on the bottom and lower right of this slide, HIV-specific factors shown across the top on both sides, and sex-specific factors such as estrogen loss experienced during menopause. Collectively, many of these traditional and non-traditional CVD risk factors influence the development of atherosclerotic cardiovascular disease, or ASCVD, which is a disease of the arteries that are central to the heart. The acronyms ASCVD and MACE are used frequently in the Reprieve data findings. So I'm going to take a moment to define what these terms mean for those who are new to this clinical area or research. So ASCVD is caused by plaque buildup in the arterial walls. And if you take a look in the upper right-hand corner of this slide and the top cartoon, the first vessel represents a very healthy artery. You can see it has rich blood flow flowing through it without any problem. Unfortunately, due to chronic elevated cholesterol levels, particularly elevated LDL, which is the bad cholesterol, and triglycerides intake, lesions can begin to form along the inner lining of these arteries and start to cause a blockage or plaque buildup, that yellow goop that you see there. Over time, without intervention, advanced lesions block the blood flow and can lead to the development of a heart attack or stroke. And if you look at the lower cartoon, that represents a slice or cross-section of an artery, that you can see that in the beginning, it's a nice smooth artery, but as that plaque begins to form and bust through the lining, MACE can occur. MACE represents major adverse cardiovascular events, and this could include a heart attack or myocardial infarction, angina, chest pain, stroke, TIA, which is a transient ischemic attack, carotid artery stenosis, peripheral artery disease, and perhaps a abdominal aortic aneurysm. Currently, ASCVD-related, sorry, I'm a little short, related conditions remain the leading cause for morbidity and mortality among the global population, and alarmingly, cardiovascular disease events are 1.5 to 2 times higher among people with HIV relative to the general population. The good news is that there are ways to help reduce the risk of ASCVD, including lifestyle changes, and that's what the Reprieve study evaluated, which is a group of medications known as statins, which lower low-density lipoprotein, or LDL, that bad cholesterol that can contribute to plaque formation in the arteries. These medications have also been shown to lower cholesterol and reduce risk for heart disease, stroke, and certain blood clots. So early on, seminal studies in people with and without HIV began to show promise of statin use reducing cardiac inflammation and cardiovascular disease. The Jupiter trial in the first box on this slide was a large randomized controlled trial among people without HIV that was testing a statin strategy to prevent cardiovascular disease events. Jupiter enrolled participants with normal LDL cholesterols and mildly elevated CRP, which is an inflammatory marker. And results demonstrated that statins reduced cardiovascular events, providing evidence that statins may have a benefit beyond just lowering an LDL, that they may actually have great potential to prevent cardiovascular disease events by way of inflammation pathways, which have been shown to be altered in people with HIV. In small randomized controlled trials in people with HIV, in the next two boxes, evaluated the impact of statins on cardiometabolic parameters. The SATIN trial, led by Dr. Grace McComsey, demonstrated that rosuvastatin lowered, which is a type of statin medicine, lowered LDL and reduced immune activation. And additional studies shown on this slide demonstrated that statins were safe and well tolerated, and specifically the statin medication known as pitavastatin calcium was safe because it had no interactions with antiretroviral therapy and required no dose adjustments. The evidence yielded from these important studies and others identified a gap in the clinical care of people living with HIV, in that there were no guidelines for the prevention of cardiovascular disease among people with HIV. Among people with HIV, cardiovascular disease has been identified as a leading cause of morbidity and mortality, even in the absence of traditional risk factors that I shared on prior slides. Studies, as I just shared, suggest that statins may have or may be a favorable approach for individuals with HIV. However, questions still remained, such as how do statins prevent cardiovascular events among people with HIV, and should they be recommended? How do they work in the setting of HIV, and who should receive them? These questions led to the establishment of the Reprieve trial. The hypothesis for Reprieve was that statin therapy will prevent atherosclerotic cardiovascular disease-related MACE among people living with HIV on antiretroviral therapy in whom traditional CVD risk is not significantly increased. As part of Reprieve, statin safety and statin effects on non-CVD comorbidities among people with HIV were also assessed. ASCVD risk score is generated from a clinical calculator. This risk score can be measured in your GP's office or your primary care provider's office. It's a calculation of your 10-year risk for having a cardiovascular problem. The risk considers factors such as age, sex, race, cholesterol levels, blood pressure, medication use, diabetic status, and smoking status. The principal investigators of Reprieve include Dr. Stephen Grinspoon, Dr. Pamela Douglas, Dr. Heather Robato, and Dr. Michael Liu. My dear colleague, Dr. Markella Zanni, whom many of you may be familiar with, she's a dear friend and brilliant scientist and clinician, and we were grateful to receive additional funding for a sub-study that was fully integrated into the main Reprieve trial to explore sex-specific mechanisms of CVD risk and risk reduction in people with HIV. Specifically, we were able to evaluate how do sex-based differences in immune activation influence ASCVD risk, and how sex-based differences in statin-induced immunomodulation, which is essentially ways that it can sort of calm down inflammation, influence ASCVD risk reduction. And importantly, we are able to explore how reproductive aging influences both of these factors among the women enrolled in Reprieve. This slide shares the Reprieve study design. Ultimately, over 7,000 people with HIV were enrolled from over 100 national and international sites and were randomized to receive either pitavastatin 4 milligrams or a placebo, and were followed on average for 5 years. Also embedded in the study is a mechanistic sub-study that looked at coronary angiography, or cardiac CT, in 800 participants before and after statin initiation, as well as many inflammatory pathways. This slide here shows in greater detail the eligibility criteria for Reprieve. Essentially, like I mentioned, we enrolled participants across the globe in 12 countries. The inclusion and exclusion criteria are listed on the right side. Please note that participants were excluded if they had pre-existing atherosclerotic disease, also low to moderate categories of ASCVD risk, and LDL were required to enter the trial. There are many important findings generated by the Reprieve trial, though in the interest of time, I will share the main finding before I discuss findings related to women in detail. So, was the treatment with pitavastatin effective to prevent major adverse cardiovascular event? The answer is yes. Among those enrolled in Reprieve for an average of about 5 years of follow-up, those who were randomized to receive pitavastatin 4 milligrams daily had reduced risk of MACE, or those events, by 35% compared to placebo. If you look at the curve in purple, this represents the individuals who were taking pitavastatin, and those in the aqua line were taking placebo. After about 12 months, you can see the curve split, and there's a difference where more people in the placebo group develop MACE compared to those in the pitavastatin group. Looking at the cumulative incidence of events at the bottom, about 2.7% of people in the pitavastatin group ultimately had MACE, compared to 4.4% of those in the placebo group. So very impactful findings. Now we will change gears and discuss Reprieve findings among the women with HIV. 31% of Reprieve participants were women. Partnering with women with HIV from the community, Dr. Zanni and I established the Follow Your Heart campaign based on the rich feedback from what women needed. This campaign was designed to educate women with HIV on cardiovascular disease in women with HIV and the importance of clinical trial participation so that we could identify findings sensitive to improve the care of women at large. You can see on the columns here in the table on the left, sorry, my pointer is a little bit fumbling right now, but you could see in the columns that 31% were women. The first column represents the percent of women enrolled in Reprieve by country, and then it is compared to the prevalence of women living with HIV within each of those countries. And of course, the map shares for you the prevalence of women and exactly where the women who participated in Reprieve resided. This table shares with you the baseline characteristics of the study population by sex, and also women you can see here are sort of in the yellowish color in the far column. A comparison of men versus female enrolled with Reprieve globally revealed that age, hypertension prevalence, LDL level, and the percent of participants with suppressed viremia was comparable between the two groups. Among women, a smaller proportion of participants reported white race. Women versus men demonstrated a lower prevalence of cigarette smoking, and importantly, a significantly lower 10-year ASCVD risk score, but a higher body mass index and a higher median CD4 count. This slide shares the rates of major adverse cardiovascular events, or MACE, broken down by 10-year ASCVD risk score by sex, with the men in black and the women in teal. Among both men and women in the placebo arm, estimated MACE rates per 1,000 person years increased along increasing 10-year ASCVD risk group as expected. Although The confidence intervals were wide and overlapping. Among those in the placebo arm with a 10-year ASCVD risk score of greater than 2.5%, the estimated MACE rates per 1,000 person year tended to be higher among women than men. So this is sort of fascinating because they had lower ASCVD risk calculation scores, but yet in this certain rubric of the ASCVD risk scoring system, they had higher rates of events compared to men. So we're going to dig a little bit deeper into that. In terms of effect size, I previously stated in the overall Reprieve cohort, statin therapy versus placebo resulted in a 35% reduction in MACE over the study follow-up. The effect size, or how well it worked, statin therapy worked, in reducing MACE was generally consistent or similar among the men and women. In terms of safety, greater than 80% in both groups remained in follow-up. Adherence was good to excellent for the majority of participants. Adverse event-related discontinuation was low and similar between groups. And all MACE events were adjudicated vis-a-vis a relationship to COVID, because this study went through the COVID pandemic. And essentially only one MACE event was definitely related to the COVID pandemic, or COVID. So just getting back to that point I was making with you, I shared that women in Reprieve demonstrated a significantly lower ASCVD risk score compared with men, though had a higher rate of MACE events in some parts of the analysis. So that led us to think, is it possible that systemic immune activation may not be well captured by ASCVD risk score, is driving MACE to a greater extent in women versus men living with HIV? And then what about menopause? What about the implications of estrogen loss? In this baseline manuscript that Dr. Zanni and I conducted before the study blind was broken, we evaluated correlates and timing of reproductive aging transition among the women in Reprieve. We determined that perhaps factors that are associated with menopause, such as increased waist circumference and advanced reproductive aging, may be sex-specific contributors to CVD risk that are not accounted for in that ASCVD risk calculator. We do know that when women transition through menopause and lose the protective effects of estrogen, it has serious implications on cardiometabolic profile, stemming from the lack of protective effects of good cholesterol, to increasing LDL levels, to increasing waist circumference. And there has been really interesting study in women with and without HIV on cardiovascular effects of hot flashes in this population. Next, the other study that was done before the blind were broken was part of the mechanistic sub-study, which found that women with HIV compared to male counterparts had increased markers of immune activation and inflammation, as well as decreased coronary artery plaque. Again, this is another interesting finding that may represent that CVD risk origins are sex-specific in this population. So, summarizing key findings in Reprieve, to facilitate this integration, it's very important to know that among women living with HIV, traditional metabolic risk factors, immune risk factors, and accelerated reproductive aging likely all contribute to increased ASCVD risk. Among a subset of Reprieve trial participants from the US, women versus men exhibited higher levels of immune activation and inflammatory markers, but a lower prevalence of coronary artery plaque. Among all Reprieve participants globally, MACE rates increased along the ASCVD risk score continuum, with estimated rates trending higher among women versus men harboring a 10-year ASCVD risk score of greater than or equal to 2.5%. And statin therapy versus placebo reduced MACE by 35%, an effect size that was consistent among both women and men. Of course, there are many more analyses that are still ongoing in Reprieve. In the context of sex-specific analyses, we will examine sex differences in immune-mediated ASCVD risk and risk reduction, and the influence of women's reproductive aging on ASCVD risk and risk reduction. This past February, in the United States, the Department of Health and Human Services and other bodying agencies released for the first time recommendations for statin therapy use in people with HIV. And this was informed by many of the Reprieve findings. This slide shows here the specific recommendations for this population, stratified by age and ASCVD risk score. I will just share that you will see that even though Reprieve evaluated pitavastatin, other statins such as atorvastatin and rosuvastatin are included in these recommendations, as pitavastatin may not be available globally, although more and more generic forms are being released. Of course, decisions for women or people at large with HIV to start statin therapy should be individualized. It's a shared decision-making process between providers and patients, and all relevant risk factors, including statin risks and benefits, should be discussed. And importantly, all conversations about risks should emphasize a heart-healthy lifestyle, ideal diet, counseling on smoking, and other CVD risk factors. This slide just encompasses the overarching important factors to help reduce heart disease in all individuals with HIV. But I want to highlight specifically for women, support for depression and mental health. Very, very important. We learned in the last presentation what increased stress yields in terms of mental health and impacts on sleep and anxiety, and these things significantly contribute to cardiovascular risk. I also would like to say that preliminary findings of our reproductive aging studies demonstrate that for women with HIV, we may need to start this conversation and assessment of cardiovascular disease earlier on in the aging trajectory, maybe soon after the age of 40, before that perimenopausal time hits, and women become at increased risk for CVD due to estrogen loss. I also want to highlight that at reprievetrial.org, all of the papers I've quoted today and all of the papers that have been published on Reprieve are available, and available via open access. Importantly, in the participant or the consumer tab, they have laypersons' summaries of each of the articles and infographics that can be shared across clinics, across community groups, so that this information can really get to those who matter. And with that, I'd like to conclude and thank you all for your attention. I really would love to start by saying thank you to the participants and CAB members of Reprieve, particularly the women who gave their time so that I could share these results today. All of our Reprieve members and my dear friend and colleague, Dr. Zanni, who is not here today, but I know that if you haven't had an opportunity to hear her speak, you definitely will in the future on this topic. So thank you all, and I look forward to the question and answer.